All right, party people, we are back at it with another one. Let's get it. So this question is very valuable. We're going to be connecting a lot of dots. It's not actually just about C-ANCA versus P-ANCA, although we will cover that. It's also about renal physiology, hematologic parameters, and vasculitis diagnostics. It can be tricky, but we're going to get through it. It's going to help you on your licensing exams. We have a 30-something female with 3 days of epistaxis. She also has fatigue, as well as a creatine of 3.8. Please note that this is extremely elevated. Normal should be around 1. The range, in theory, should be from 0.7 to 1.2. Now, in elderly patients, your creatinine may creep up to, let's say, 1.1 or 1.2 as they age, let's say, into your 90s. But quite frankly, you should be looking for it to be around 1. If you get to creatine 2.0, that implies that you've lost 90% of your renal function. So a value of 3.8, this is profound renal failure. We're essentially looking at no renal function whatsoever. We have antibodies at antiproteinase 3. This is very specific for C-ANCA, aka granulomatosis with polyangiitis, GPA. Now, this is formerly known as Wegener's. The option choices below, we know it's going to be C-ANCA positive and P-ANCA negative. So P-ANCA, for comparison, is anti-myeloperoxidase, MPO. This is seen in microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis, EGPA, formerly known as Churg-Strauss. Now, in terms of the GPA clinical triad, here we're going to be looking for an upper respiratory involvement, thinking sinusitis, otitis media, nasal septal perforation, etc. Lower respiratory tract involvement, such as cough, hemoptysis, or pulmonary infiltrates, as well as a renal involvement, such as hematuria, red cell casts, or RPGN. Now, on the renal biopsy, I know that you're not a histopathologist, but I'm giving you an image that you may or may not recognize just to kind of freshen you up. So if you see this renal biopsy, let's say that you do not know what you're looking at, but instead they write in your question, if they say necrotizing glomerulonephritis is present, especially in a patient with sinus symptoms, otitis, hemoptysis, your answer will be Wegener, aka GPA. So in Wegener's, you will have necrotizing glomerulonephritis, you will have red cell casts in urine. This indicates glomerular pathology. All right, we're going to get into the trickier part of this question, which is going to be addressing the renal failure and as it relates to blood urea nitrogen, the BUN level. As BUN levels rise, this may lead to uremic platelet dysfunction. This is a qualitative disorder, not a quantitative disorder. So, in this case, your bleeding time will be elevated, but your total platelet count will be normal. Just to clarify, uremia is not hyperuricemia. Uremia is the clinical syndrome of renal failure. Toxins build up, symptoms develop. Hyperuricemia is the elevated uric acid levels, which are unrelated. Now, in uremic platelet dysfunction, you will have an increased bleeding time, normal platelet count, as well as a normal PT and PTT. This is also known as acquired platelet dysfunction. This is classic in renal failure. Now, this dysfunction leads to mucocutaneous bleeding. So think epistaxis, petechia, despite a normal platelet count. On your licensing exams, this is counterintuitive because if you see bleeding, most people think platelet counts must be low. This is not the case because in uremia, the count is normal, it's the function that's impaired. Now, bleeding time is normally 2 to 7 minutes. In uremia, it's going to be above 7 minutes, despite the platelet count remaining in the 150 to 450,000 range. So the correct answer here is increased bleeding time, normal platelet count, C-ANCA positive, P-ANCA negative. Now, in the case of this epistaxis, what is the cause? The common misconception is that the patient has low hemoglobin. It must be anemia of chronic disease. In theory, that is possible. But remember, anemia of chronic disease does not cause bleeding, okay? So this would be a symptom, not a cause. Now, the patient's epistaxis is due to the uremic platelet dysfunction, not anemia of chronic disease. Now, the patient may have anemia of chronic disease due to the chronic renal failure, but the epistaxis is a platelet issue, not an anemia issue. This is important to distinguish. You have to be clear on this. Now, I'm going to give you a few additional high-yield points for this. In terms of anemia of chronic disease, in renal failure, you will see normocytic or mildly microcytic anemia. This will be due to decreased EPO production, and you will treat this with recombinant EPO, such as epoetin alpha. Now, for treatment of Wegener's, aka GPA, induction will be corticosteroids plus cyclophosphamide or rituximab. Maintenance will be methotrexate, azathioprine, or rituximab. And finally, plasmapheresis for severe RPGN or pulmonary hemorrhage. So let's spin the block and review what we just covered. If you have C-ANCA positive / anti-PR3, this is positive for Wegener's or granulomatosis with polyangiitis. The triad that you have to remember is for sinus involvement, lung involvement, as well as kidney involvement. Renal biopsy will show necrotizing glomerulonephritis. Epistaxis in renal failure is due to uremic platelet dysfunction, where you'll see increased bleeding time as well as normal platelet count. And anemia of chronic disease does not cause bleeding. All right, that's it for this one. Go crush it.